VB stent, is a landmark in interventional cardiology for percutaneous closure of sinus venosus ASD. This video discusses the concept of the device and its clinical applications. There are different types of ASDs, of which sinus venosus defect is situated at the SVC Junction, often associated with anomalous pulmonary venous drainage of two or more pulmonary veins, commonly arising from the right side of the heart, as demonstrated in the illustration. More advanced imaging and 3D visualization demonstrates the anatomy of the defect much better. Here you can see the sternum and the right heart closely related to it, with the superior vena cava coming down into the right atrium and pulmonary veins attached to the lower end of the superior vena cava. This view further illustrates the spatial orientation and location of the pulmonary veins into the different aspects of the SVC as it joins the RA junction. In this picture, the spatial orientation of the differential pulmonary drainage is well appreciated. You can also appreciate the change in calibre of the superior vena cava as it reaches the right atrium, as more and more pulmonary veins drain into it. The insertion of the pulmonary veins at various levels and dimensions of the superior vena cava at each level can be measured using virtual imaging techniques. Virtual sections can also be made as shown here, wherein the size of the atrial communication and change in calibre of the SVC is better appreciated. Using transoesophageal echocardiography, the higher location of the sinus venosus ASD in the atrial septum is better appreciated, and the left-to-right shunt is easily visible on color doppler imaging. Here you can also appreciate the pulmonary veins draining into the superior vena cava. CT scan allows measurement of the superior vena cava at various levels by using standard techniques. 3D printed models derived from CT or MRI images gives much better insight into the anatomy and location of the pulmonary veins in relation to the superior vena cava. These images illustrate the drainage of pulmonary veins change in calibre of the superior vena cava, as well as variation in the size of it in small, medium, or large-size patients, depending on the body surface area. To accommodate the variation in the size of the superior vena cava, an ideal device to divert the pulmonary veins into the left atrium without causing obstruction to the systemic venous return requires a stent with graded dimensions, as illustrated here. Such a device will comprise of a proximal flared uncovered area to anchor the device to the SVC Nominate junction, followed by a proximal flared area, a central covered area, a distal transition zone, and a distal flared covered area, and possibly a distal flared covered area as well. Based on the metrics derived from numerous 3D printed models, the final device configuration of a transcatheter device that is a VB stent needed 3 different lengths, 65 mm, 75 mm, and 90 mm to cover all sizes of the patient. Here is the profile of these devices from various angles. Numerous metrics were derived to compose the final device as illustrated in this table. Virtual implantation of the device in segmented multimodality imaging confirmed the adequacy of the device to cover all variations of sinus venosus ASD in more than 50 patients. In this illustration of virtually implanted device, one can appreciate the smooth flow of pulmonary veins directed to the left atrium using the VB stent. In some samples, closeness of the azygos vein in its proximity to the right superior pulmonary vein necessitates the need for occlusion of the azygos vein prior to the placement of the VB stent. Virtual 3D model helped to define the variation in pulmonary venous drainage and implantation of the device in 3D printed models, and further enhance the device development. This illustration of VB stent in 3D printed models highlights the utility of 3D printed models in device development for congenital heart defects, without the need for animal experiments. The 18 French delivery system into which the device is incorporated and comes preloaded is accessed from the right internal jugular vein using Seldinger technique through the delivery system highlighted here. Intraprocedural transoesophageal cardiogram is useful as an adjunct along with angiography for the device placement. The device can be repositioned, recaptured, and deployed any number of times prior to the final release. Here you can appreciate the device in position with unobstructed superior vena cava drainage and pulmonary venous flow into the left atrium. A post-procedural CT is helpful to understand the device profile and its relation to the pulmonary vein and superior vena cava. As visualized here, the device is well located within the SVC, commencing at the junction of the superior vena cava with innominate vein and internal jugular vein. The right upper and middle pulmonary veins can be seen skirting around the covered portion of the stent with complete closure of the ASD and no obstruction to the venous return. Currently, the VB stent is available in 3 sizes: 90 mm, 75 mm, and 65 mm in length, with the proximal end measuring 25 mm, 24 mm, and 20 mm, with the distal diameters measuring 38, 35, and 32 mm respectively. The proximal and distal transition zones accommodate the change in calibre between the large diameter of the SVC RA junction to the proximal flared end. The proximal flared end has a 7.5 mm additional uncovered area, with a 15-degree further angulation to the flared end, to ensure adequate stability of the stent both at the sinoatrial junction as well as the junction between the innominate vein and internal jugular vein. Our early experience from human implantation of the VB stent has been extremely rewarding and encouraging. The implanters have felt the ease of use and simplicity of procedure without complications as the most important aspect of the device. We are expecting the device to be available by proper approval process within the next few weeks.